Okay, so the title that I chose today is Beyond Silos and the Status Quo, a New Era of Dementia Care Services. And I'm so excited about the two projects that I'll be talking about. So two disclosures. One is that I do receive some salary support from Centene Corporation, and that is to help them implement the Mind at Home model of dementia care. And then I also receive less than 1% salary support from Craniometrics. That's a technology platform, and you'll soon understand why. And so I'm hoping after today's talk that you can describe at least one way, preferably two, that we can provide dementia care, and I'm talking about good quality dementia care outside of the office setting. I think I'm really good at what I do, and I'll argue that it's woefully inadequate for what our patients with dementia and their caregivers need. And so, brief outline, I'm going to kind of set the stage with dementia, just a little definition and the scope of the problem. Then I'm going to talk about memory core and the early results of this randomized controlled trial, and then a brief review of Mind at Home, which is a model of dementia care management, and introduce you to the guide model. And I'm just going to say that the guide model is the biggest news that no one has heard about. And dementia care is literally the biggest thing, no words, so you'll see. It's a lot for our patients. Good news. Okay, so what is dementia, or major neurocognitive disorder? I'm going to use dementia for this talk. And so I think that it's really helpful to think of dementia as brain failure, because a lot of our patients understand kidney failure, heart failure, so dementia is brain failure. Most of the time, that's due to pathology associated with Alzheimer's disease, but it can also come from Parkinson's disease, brain vascular disease, etc. And what we see in dementia is that we see a progressive cognitive decline and a secondary functional decline. So cognitively, we see things like short-term memory loss, become rapid forgetting, become long-term memory loss. Some of my patients with dementia just can't even recall their names or really basic biographical data. And then we see changes in language. So, we all have a little bit of tip of the tongue phenomenon, but really changes in someone's ability to express themselves. And that expressive aphasia, then there's a receptive aphasia. They can't understand what other people are saying to them, and then it really renders verbal communication really difficult, if not impossible. And then we see other changes, like changes in praxis or ability to do things. And I tell patients and their families, I tell their families, anything that you ever learned can be forgotten. So you had to learn how to dress yourself, as an example. And then we see changes in ability to recognize people, places, and things. And in later stages, someone often doesn't even recognize their spouse or their child. And then throughout, we see executive dysfunction and changes in decision-making, judgment, impulsivity. So a really wide range of cognitive changes. And then functionally, early on, we see trouble with high-level activities like driving, banking, managing medications, and then it becomes much more personal, where activities of daily living are impaired. And so someone needs help with dressing, bathing, toileting. Inevitably, we see incontinence in dementia. And if someone lives long enough, unfortunately, in the severe stage, oftentimes someone cannot walk, talk, or feed themselves. So I say all of that so that everyone can appreciate this is just a devastating disease. And we don't have a cure, of course. And you may have heard, in the news about the anti-amyloid therapies. And we've made strides in early diagnosis and then ability to intervene with these therapies, but that's really for a limited group of mild stage patients. And in the meantime, I have this whole group of people that I'm trying to care for, and we manage dementia much like we manage other chronic illnesses. And so, as if the cognitive decline and the functional decline aren't bad enough, we see the neuropsychiatric symptoms, and the Cache County studies tell us that those are nearly universal. And that's why I'm busy, right? The neuropsychiatric symptoms. And so we see apathy, depression, anxiety, irritability, agitation, aggression, psychosis, restlessness, wandering, the whole gamut. And caregivers will tell you that that's the problem. The problem is less so the forgetfulness or trouble with dressing or bathing. Those are hard enough, but these other symptoms, the neuropsychiatric symptoms and behaviors, those are the challenging part. And we have one FDA-approved medication for behavioral disturbance in dementia, one. but a pill is not going to fix that. And so it's really about behavioral interventions, but that takes knowledge, right? And I impart the knowledge largely. It takes time, it takes energy. Caregiving is a really hard job. And so kind of that's where we are. And so amongst the things that patients need, so people with dementia, they need meaningful activities, they need daily structure, they need engagement to help lessen those other symptoms. And then the caregivers need a break, like they need respite. And so the 36-hour day, like by our own Peter Rabins, that title is the most apt title, no idea. And so a bit about scope of the problem. So I would argue that dementia is a public health crisis. And I think that people that don't do dementia work don't realize it, because oftentimes people with dementia are kind of, they're at home, right? Like we don't see them as much. But unfortunately, almost 7 million Americans are living with Alzheimer's disease and related dementias. It's incredible. And it costs a lot of money. Big numbers don't mean a lot, but what I can tell you is that 1 out of every 5 Medicare dollars, soon to be 1 out of every 3, is spent on someone with dementia. And here we spend a lot of money. It's a costly disease, like emergency room visits for what otherwise is a simple UTI, hospitalizations, skilled nursing. It's an expensive disease, and their outcomes are poor, right? That's a terrible mismatch. And the caregivers are often older adults themselves. So their spouses, but then also the grown children. If I have a patient who's 85, their oldest daughter is probably 60 or 65. So it's a high burden disease. And the caregivers have high rates of stress, depression, financial. This is such an expensive disease. And what patients need, it's not covered by insurance largely. My visit is, but a lot of other things they need are not. And I'm going to argue that we need new approaches. We need to help our patients differently, their caregivers differently, and the healthcare system at large needs a change. And so I don't know how many people in the room caught this study, but in my world, this was really big news. So this is 2023, and this I just photoshopped right from the abstract. And so in the U.S., the highest prevalence of ADRD, Alzheimer's disease and related disorders, we are the state, Maryland, with the highest prevalence, and they called out Baltimore City, right, like in the abstract. So we're in the epicenter right here. And so now I'm going to shift gears to talk about memory core, and I'm going to kind of breeze through. And the main thing that I want you to take away is just how we're thinking about dementia care, and maybe that can translate to other conditions that we treat. So Memory Core, a wonderful project between Johns Hopkins and the Alzheimer's Association. And let me just say, I happened into Memory Core. Deirdre Johnston retired. I happened into Memory Core, and I happened into Mind at Home. And it's been amazing, amazing. So Memory Core, making engagement meaningful through organized routine interaction. It's genius, honestly. And so a novel activity-based program, so essentially using an already existing evidence base. Quincy Samus, Deirdre Johnston, and the team devised Memory Core. So using this evidence base, could you have a program in which you deliver personalized, individualized activities to a person living with dementia in their home to help them and their caregiver, that educates the caregiver, that gives the caregiver a break? And the person that provides that is a senior volunteer, someone over 55 years of age who is trained to do this. And so it really is designed to be a win-win-win. And it's using evidence-based resources. And so the big 3 goals of Memory Core, so you want to provide companionship, personalized activity to the person with dementia, and supporting the care partner. So they learn these activities that their person enjoys, and they get a break, they get some respite. And then to provide meaningful engagement, et cetera, to the trained volunteer, the senior volunteer. And an overarching goal is trying to combat social isolation and loneliness. And we see more and more research that social isolation is a risk factor for developing dementia. And so very briefly, this Memory Core program, this activity program, was turned into a small randomized controlled trial supported by the NIA. And we're looking at feasibility, efficacy, and essentially you take a dyad, so the person with dementia and their caregiver that live together, they're a dyad, right? They're a unit, and then you have the trained senior volunteer companion. And it went on for 12 weeks, and so we have measures for the person with dementia and the caregiver for 12 weeks, following the senior volunteer for a whole year, looking at various outcomes measures. And of course, this was designed to be provided in the home, like literally physically in the home, but then COVID. So it was changed to virtual. And 175 people enrolled, and basically one-to-one, person with dementia, their companion, and the senior volunteer. And I'm not going to go through this whole piece, but what I want to point out is that these activities were not randomly chosen. So an activity, an evidence base, and a very skilled occupational therapist, and someone from the School of Nursing, and Quincy Samus, and myself, someone from the Alzheimer's Association, really interdisciplinary, and there were weekly meetings all along with the trained senior companion guides. So what's going well? What do you need? I gave some didactics. I infused learning. They infused learning. It's really, really meaningful. And so some of the outcomes, does this intervention that I've described, does it improve quality of life for someone with dementia? Does it decrease those behaviors, right? Those neuropsychiatric symptoms that are so challenging. And for the caregiver, does that lessen their burden? They're feeling supported and they're getting some time to themselves. And do we see less depression in the caregiver? And then for the senior, do we see things like improved social engagement? And do they have better cognitive outcomes? And so it went for 12 weeks. They met 1 to 5 times a week, about 45 minutes by Zoom. And over the course of this study, we cataloged over 675 individualized activities, kind of grouped into categories. And I have a picture here of one success story. So in the bottom right, you see the companion guide, and she's working with a gentleman with cognitive impairment who loves football, who loves the Eagles. And the companion guide got this lovely gentleman, this tight end from the team, to appear live on the Zoom. And he's just this is the epitome of individualized, personalized care. Really great story. And so I'm not going to talk about this in detail, still early, but the bottom line from the family satisfaction survey is that it worked well. The family care partners rated high satisfaction in almost all 22 of the domains. And some of the most highly rated areas were that the volunteer was professional, that they showed respect for the person with dementia, that they could help them to feel comfortable. So really, really good. And then in terms of the person with memory challenges, also overwhelmingly positive, but the highest ratings were that the person with dementia enjoyed the volunteer's company and the activities themselves, and there weren't any adverse events, everyone. How about that? That's really good. And then in terms of the caregiver, the number one positive outcome that the caregiver reported is that it made them happy to see their person with dementia engaging with the volunteer. I think that says a lot. And so where are we going next? So this is super early on in terms of the data analysis, because we've been working on what I'm going to talk about after we meet my patient. But we're planning on having a larger, hopefully getting research funding for a larger multi-site clinical trial. And then that trial would have all 3 arms, right? The original physically in-home program, the virtual, and then the wait list. And I forgot I don't think I said that before, but that the dyads were randomized, either the program or waitlist control, and then they crossed over. And something that I'm really interested in is this an intervention for the trained senior volunteer companion guide? By helping someone else with dementia and their caregiver, does that reduce their own risk of developing dementia because of the cognitive stimulation and the socialization and such? It's just amazing, actually. And then we're looking to pair with a large delivery partner, maybe like AmeriCorps or some group that has a lot of volunteers at the ready. And so I'm going to take a break there, and I think that my patient has arrived for the interview.
Debbie, thank you so much.
Okay, so we talked about memory core, so let's talk a little bit about Mind at Home and the guide model, which, like I said, the guide model, it's really exciting news for our patients. And so the Mind at Home piece might be a review for some of you. So Mind at Home, born and raised here at Johns Hopkins, been around for about 15 years. So Deirdre Johnston, Quincy Samus, Halima Amjad, this has been their big project. And so Mind at Home, maximizing independence at home, that's evidence-based dementia care navigation. And I'll tell you, in my office, like oftentimes that's what my patients need. They need someone that's like a nurse, a social worker, someone to really meet them where they are and guide them along the way. And so Mind at Home, it's comprehensive management for persons with dementia, and it's scalable. And essentially there's a memory care coordinator or care navigator, whichever term you want to use, supported by an interdisciplinary team. That would include someone like myself. And the Mind at Home model has shown to be successful in various settings, including some managed care programs. Right now we are in Pennsylvania, Texas, Florida, and then here, Johns Hopkins Home Care, they have Mind at Home, but it's private pay. And we know that it's effective. It's an effective strategy that both improves outcomes and reduces costs, right? Like that's the golden ticket, better cost, less pay. And unfortunately, even though we know that at a systems level, Mind at Home saves money, for an individual, it's expensive, right? Like it's private pay, and most of my patients could not afford that. And so how it works, this is like one of our Mind at Home, like most famous slides. It's a bit busy. But essentially where it starts is that home is the nexus of care. And there's an in-home assessment by that care navigator or memory care coordinator that I mentioned. And then it's a very comprehensive assessment, and then that generates an individualized care plan. And then you implement the plan, kind of revise, and reassess. And so something that's really important about Mind at Home is that it takes into account the needs not only of the person with dementia, but also their caregiver. And the Johns Hopkins Dementia Care Needs Assessment has 13 domains? Yes, 13 domains for both the person with dementia and their care partner. And they're both medical and non-medical. So people with dementia have a lot of non-medical needs. And some of the most common needs that we have found are things like home and personal safety, general medical care, meaningful activities that I mentioned, and then the caregivers need lots of education on memory disorders. They have legal concerns, and then they need their own mental health care. So those are some of the top needs. And then some of the short-term goals are to reduce these unmet needs. That's a big dementia term, unmet needs. And we want to maximize quality of life, reduce those dreaded behaviors I mentioned, and then have appropriate use of healthcare services. So less of the acute care setting like the ED and more in-home care. And then overall, we want to reduce the caregiver burden. And long-term, we want our patients with dementia to stay well at home, and we want to provide better care at less cost. And we can do this with Mind at Home. And so this is a long, detailed research summary slide, which I'm really sorry, the references are cited, but I didn't actually put the notations at the bottom, but I can get them for anyone. But some of the biggest outcomes that we've had are that Mind at Home, as I said, reduces unmet needs, improves quality of life. It does reduce the burden for the care partner and delays transition to a nursing home, which nursing home care is incredibly expensive, and I would argue it's not high quality. It changes those utilization patterns away from acute care. And so I'm not going to go through this slide, but these are really practical examples that you can kind of grab onto. What can a care navigator do? And so at the top of the list gives an example of how, by educating a caregiver, when the person with dementia had an infection like a UTI, we were able to treat that infection rather than going straight to the emergency room when a behavior started. It can be dramatic in someone with dementia. But the one that I want to point out that goes with a picture is this lady. This is like Mind at Home lore. This is like one of the best success stories where this lovely lady did a lot of picking. So we can see someone with dementia, they can be a little restless and busy. So picking at her skin. And so they designed a twiddle muff, and a twiddle muff is basically like a tube that has all kinds of sensory stimulation inside and out. And so the legend goes that when they gave her the twiddle muff and she put her hands in, she just relaxed and smiled. And I thought she was wearing a fabulous hat. That's just a doily on the back of the chair, but it's the best picture. And so that's Mind at Home. We have this model, we know it works, but it's not paid for by Medicare until, this is the biggest news nobody's ever heard of. So in July of 2023, the Biden-Harris administration announced the guide model, kind of quietly announced the guide model. And I'm going to tell you about GUIDE because it really affects our patients and their caregivers. So GUIDE, Guiding an Improved Dementia Care Experience. So this is from CMS, and this is their innovation branch. And it's an 8-year voluntary model. And so voluntary in that, providers, clinicians like ourselves don't have to do it, and our patients don't have to accept the benefit, right? It's voluntary. And it's basically an alternative payment methodology that pays us, whoever's doing GUIDE, pays us to do dementia care navigation, and there's money for respite. It's incredible. One of those things that you've always wished that Medicare would pay for. And what they're paying for is a standardized set of services for someone with dementia and their caregiver. And big goals: improve quality of life, decrease nursing home payment, and helping people to stay in their homes through the end of life, not die in the hospital. And so this announcement came out in July of 2023, and then we were waiting for the application. You have to apply to be able to do this GUIDE program. And so that came out in November. Hopkins applied. We are one of the participants. Last I saw, there were 381 sites, programs across the country, and it's expected to reach over 200,000 patients, which I gave you numbers earlier. It feels like a drop in the bucket, but it's a start. And the biggest thing is that if we can show that GUIDE works over these 8 years, this is like a test. If we can show that GUIDE works, it could become a permanent benefit for Medicare recipients, which would be amazing. This is like the most famous GUIDE slide, any of the CMS meetings, but I want to point out 3 things. So what the GUIDE model provides is care coordination and management. We've talked about that already. Caregiver support and education. So literally things like educational classes for caregivers. And then respite services, up to $2,500 a year, up to $2,500 a year for a Medicare beneficiary. There are strings attached to that, of course, and how that money can be used, but I can tell you that some of my patients in the local area are so under-resourced, they can't even pay someone to come and take care of their person for 2 hours to go to church. Like, this is amazing, actually. And so this is a busy slide, but just what I want to tell you from it is that from a patient perspective, it's not hard to get these benefits, these services for GUIDE. They have to be traditional Medicare, and they're not in a nursing home, they're not on hospice, they're not in the PACE program at Bayview. It's pretty easy, and they, of course, have to have a dementia diagnosis, right? That's what this program is for. So people on traditional Medicare with dementia. And then based on the severity, so either, well, 2 combinations, the severity of their dementia and the needs of the caregiver burden, those 2 factors determine where does this patient and their caregiver get placed, like in the tiers. And higher tier means more reimbursement, right? And we expect that most of the patients will be in that kind of moderate tier. And so that's how the patient gets in, that's how they qualify. So in terms of us, like, what does the team look like and what do we have to do for this GUIDE thing? So the interdisciplinary care team is really just the care navigator and someone like myself, a dementia proficient clinician. It's us managing. And the care navigator, one of the best parts is that the care navigator doesn't have to be a nurse or a social worker, but they have to have a standardized set of training. And I have that list here. It's, I think, 12 topics through CMS. And fortunately, before GUIDE was ever announced, Quincy, Halima, Deirdre, and myself, we put together this Johns Hopkins Dementia Care Specialist certification. So it meets those requirements, and now we get to market it to help educate care navigators around the country. And so you've got that team, so what do you have to do? So also a busy slide, but it's really the things that I mentioned from Mind at Home, right? The comprehensive assessment, care planning, and Mind at Home is perfect for this. And Mind at Home was actually one of 6 evidence-based dementia care models that CMS used to design Guide. So they based Guide off of us, so we can do Guide really well. And this is important, 24/7 access you have to provide to these patients and their caregivers by phone. So that's to avoid trips to the emergency room overnight, as an example, 911 calls. And there's at least a monthly contact and then a yearly assessment. And so some of the outcome measures, because CMS is looking for outcomes. So things like use of high-risk medications, and that's done by the clinician. That's not the care navigator's job, right? The medication piece. Better quality of life, less caregiver burden, decreased total per capita cost, and then the beneficiaries, less chance of going into a nursing home. So really important goals that we know Mind at Home already does. And I made this special little flag because I think that this is really important. So one of the goals of Guide is to advance health equity, right? So the spirit of Guide is to offer these services to our patients who can't afford to pay for a care navigator, who can't afford respite, and who need this education. So really our most under-resourced patients. And so how are you going to do this, right? Like, it's a lot to keep track of. All of these participants, all of the requirements, and then the billing, it's a lot to keep track of. All your monthly contacts, everything. And so, we're going to leverage technology, leverage AI. And so various platforms have, come out of the woodwork. But Craniometrics is an established platform that we actually have paired with to be able to implement the Guide model, Mind at Home and Guide. And this makes it easy and scalable, profitable. And so we, Mind at Home, exquisitely paired with Craniometrics. That's the announcement from our Johns Hopkins website. And they have an AI-assisted platform, but we're working collaboratively to do Guide, to provide those services. That's just a schematic, but the thing that I want to mention is that our joint product is called Care Central, and that platform, interestingly, has 2 sides. So it has a side that I, as the dementia proficient clinician, I can access, the care navigator can access, and it's going to integrate with Epic. And then there's a patient-facing side. So let's just say my patient has developed, let's just say, sleep-wake cycle reversal. I can push educational materials from Mind at Home. I can push educational videos to the caregiver to use at their own time. It's pretty neat. And so big news is that Johns Hopkins got approved to do Guide, but because, as we all know, the School of Medicine is really risk-averse, we weren't sure that we were actually going to be able to deliver. Because this is a big commitment. We have to do a lot of things to get this reimbursement, and it's a tight margin. There was concern that it'd be a money loser. Fortunately, it was approved at the end of last month, and just a huge deal. And so it's a partnership between geriatric psychiatry and geriatric medicine, going to be housed on the Bayview campus, Casas Laquetzos in the Memory and Alzheimer's Treatment Center. That's kind of going to be the home base. And we are going to be using Mind at Home as the model of care and Craniometrics as the platform to make it doable. So we are building. We just got the okay. We are building the program. So a lot of details I don't know, but we will start enrolling patients in July. So big, big news. And I meant to say estimated 250 patients. The target has changed in the first year, but it'll be rolling, of course. So initially in the memory center, memory clinics, kind of enrolling our own patients, and then we'll expand to, say, primary care within the Johns Hopkins system and then into the community. But we have to do it slowly. We can't enroll everyone all at once, of course, and we need to do this well, remember. And then I just wanted to really do a shout out to Quincy Samus and Halima Amjad, who really have spearheaded. I mean, they have Mind at Home, and they spearheaded and worked so hard to get this approved. And they also created, we created a regional Guide alliance. So there are 4 programs in Maryland doing Guide, MedStar being one. In the collaborative spirit that women, that's how we are, really formed an alliance so we can all share resources like vetted respite providers. As an example, we don't have to reinvent the wheel. It's very collaborative. We all want it to work. And so in conclusion, dementia is high prevalence, high cost, high burden. Memory Corps that I talked about in the beginning shows promise in delivering companion care. Mind at Home, it's an evidence-based dementia care navigation program started here at Hopkins. Medicare is piloting guide to pay for those services. And if we pair Mind at Home and craniometrics, I think we can do this in a very feasible way. And we're entering a new era of dementia care service delivery. And any questions? And the last time that I was feeling this anxious, I danced for the memory ball. And you see me walking out. I thought I was going to die. And then I dissociated. And then you see my beautiful lines. So thank you all. Thanks for listening.
You did a terrific job, Dr. Fields. It reminds me of the Dance Your PhD competitions. Oh. Thinking of Dance Your Grand Rounds presentation would be a whole new ball game. That was really interesting. What a great opportunity this guide model sounds like it is. Let me ask you this: with regard to the opening, with regard to the launch of it at Bayview, is it something where there's going to be enormous numbers of people eligible and more competition than there are slots available, or is it, or are there going to be all kinds of ways in which people don't qualify, and so the numbers won't be so great?
It's a good question. People can hear your question, right? And so we don't know.
It actually is good to repeat it for the people at other hospitals like that.
Yeah, and so the question is, is there going to be a big backlog or a wait list, or kind of how is the microphone?
So it is. Right.
How is that going to go? We don't entirely know. What we suspect is that even though all Medicare beneficiaries will get notices of this benefit, I suspect that people will not be banging down the door. That's what I suspect. And so just really people have not heard of Guide, which is kind of okay in the sense that it gives us time to do it gradually and do it correctly.
Yeah, thanks. Questions? Dr. Bienvenu.
CMS has been very vague about that, even though, the contract that we signed is like 95 pages long. But in terms of category, I suspect anticholinergics, benzos, opioids, that category, but it's a little bit unclear how we actually are going to navigate that. Especially, I feel like I do very careful prescribing. So sometimes on a risk benefit, some of my patients need that medication, so we don't really know what that's going to look like. We don't want to, for metrics, be forced to stop medications that actually benefit our patients because we've gotten to be that desperate. This is a challenging group. That's a good question.
Great. Thanks, Dr. Scharf.
Yeah, that's okay. So the question is generally that there's a lot to learn, steep learning curve in dementia, and that's difficult for a caregiver in particular. And so what have I kind of used in my practice? Yeah, so I do a lot. I have to say I learned everything I do well in dementia care. I learned from Peter Rabins. That's what I tell people. So I'm pretty upfront about what I'm noticing or what I'm concerned about. I'm concerned that X, to try to assess someone's ability to understand a prognosis or understand their needs, or like if I see a caregiver whose health is declining more quickly than my patient with the dementia, then that's one of those where I say I'm really concerned that essentially you're going to end up in the hospital and die before the person that you're caring for, and that's a disaster. And so we need to get you some help. Like basically we need to save you to save my patient. So my strategy has been very pretty straightforward, but then I'm limited with the resources that I know. And so most often I send patients to the Alzheimer's Association, which part of the reason I danced for them, like that's a misnomer. It's all types of dementia, and they do have a 24/7, 365 call line. So ultimately I often do refer or sort of ask colleagues, but it's very patchy. And our patients who most need the resources are out there and I don't know about them. So to have somebody literally out in the community who knows things and can get help with various benefits and such, it's really a game changer, honestly. And who has more time to do it.
Thank you. Other folks? Dr. Lehman.
Yeah, so I'll repeat the question. So GUIDE program has a lot to offer in terms of benefit. Is there anything that patients and caregivers have to give up in order to be a part of GUIDE? No. That being said, you can't have GUIDE along with things like hospice benefits or PACE or such. So there may be some choices to make there, but no, it's really all benefit as far as we can see. We'll know once we get there. And patients can withdraw at any time as well. I don't know why they would, but they can.
Thanks. Other folks? Dr. Morrow.
Yeah, I'll repeat that question. Good one. And I think this is good for the trainees in particular. So how do I navigate having a patient with dementia and their care partner also needs my help? So how do you navigate treating both with limited resources? I specifically don't treat both my patient, someone with dementia, and their care partner. And so we, not that Lou has dementia, but Lou did not come back to see me. So time had passed and then we connected. But I don't simultaneously, primarily because I have trouble. I'm really big on knowing who's my priority. Like this, and I feel like if I have two people who are in a relationship, but I also don't treat married couples, but that's why I have colleagues like you, Dr. Morrow. We can do a little I'll see this person, you see that person. Yeah, fortunately I have wonderful colleagues who almost always, with maybe a little bit of weight, can treat. But I would have a really hard time balancing the needs because they're often conflicting of the person with dementia and their care partner.
Dr. DiPaolo.
Thank you for that talk. Terrific.
Welcome.
Point. I 10 years ago, I was asked, I wanted to give a talk on depression. So this is the question about Lou. The women in Naples, Florida, told me I could give that as long as I would also talk about caregiving. A woman from Sweden in the audience was wanted to inform me that in Sweden, she got extra Social Security money right into her paycheck. She got a paycheck because she was on Social Security, but it increased when she get caregiving. It seems like we probably have a long way to go to get to that level. Is that right?
Yeah, so Dr. DiPaolo's question was about basically that we don't in our system that we don't pay for caregiving. You're exactly right. And there's a lot of data on incredible amounts of money in unpaid caregiver time or informal caregivers. That's the bulk. The vast majority of dementia care is provided by people who are informal caregivers, as in they're not paid. It's really a huge systems issue that I'm hoping that this is a start at alleviating some of that. Great question.
Anybody else? Dr. Bray, last question. Go ahead.
Really phenomenal talk. I think it's a really exciting
Yeah, I'll repeat that question. Dr. Bray's question was, do I think that over time, as we're doing the guide model, that was a great slip, the guide model, that the costs will decrease? I suspect that as we, in terms of cost on our end, as the program participating, I think that as we get up and running and we're not reinventing the wheel and we have our go-to resources and respite, and as we have more care navigators, we'll start with 1 and then go to 2, because a care navigator can take maybe 125 or something patients. So I do think from our standpoint, it will be more cost efficient. And then in terms of what we get paid, and I forgot to mention on the slide where there were the tiers, the amount per month is something between, and it's adjusted by area, but like $65 at the lowest amount per beneficiary per month. And I think the highest on that slide was like $390 for the most intense needs. I mean, that's like a high touch, high need population. But I think that we will be able to get that money with less expenditure on our part as we learn to do this and become more efficient. And there will be so much data gathered as you were talking, because you like to write and publish. There will be so much data gathered over this 8-year period, just umpteen papers and ways that we can understand the needs of our patients.
Great job, Dr. Fields. Thanks so much for this terrific work.